Mary Kay, Nancy, Nate, and Danny, our traffic safety liaisons in Illinois, our wonderful presenters for you, the continuing professional development staff here at SIU, Laura, Jennifer, Barb, and Ron, for hosting this virtual conference, taking registrations, and everything else they've done in between. And for my conference throwing sidekick, Jennifer Tony. Now, a few reminders before we begin. As a participant, you will not have the ability to turn your camera or mic on. Sorry. Most of this conference is being recorded. Information on how to access the recordings will be distributed following the conference. The recorded sessions are informational only. No credit will be issued. The chat box will be open during the entire sessions. Please feel free to network and brainstorm back and forth in the chat box. About 15 minutes before the session is over, the Q&A box will be open. Please type any questions for presenters in the Q&A box, and after the presentation is over, the moderator will try to get to as many questions as they can. I would leave the participant packet that you received in your email yesterday open on your computer during the length of the conference. After the general session is over, close the browser. Go to your participant packet and click on the link of the next session you would like to attend. If you are planning on stretching or grabbing a drink in between sessions, please log into this session before you take your break. The fewer items you have open on your computer, the better. The more items you have open, the slower WebEx will work. Not every session is worth a CPS CEU. Please look at the sessions carefully and only choose one that says CEU if you need to collect all 6 CEUs. There are some wonderful sessions that are not worth the CEU as well, just make sure you are aware. If you are joining the conference by phone only, please be sure to report your participation to us. Call-in users need to email ocpd@siumed.edu to earn credit for participation. If you experience issues with the audio, you may join by phone in addition to logging on your computer. Within 1 week, look for an email containing a link to the evaluation and instructions on how to download your certificate. Please take the time to fill out the evaluation when you receive it. This gives our presenters helpful feedback and helps us plan for future conferences. Be aware that there will be a short evaluation that pops up after you close the browser. That is not anything we see, that is just for WebEx, and it's nothing that we could take down. Now that I have said more than enough, I'm going to turn this over to the wonderful Thelma Kuska to introduce our first presenter. But first, just a few things about my friend Thelma before I turn it over to her. She has been a CPS instructor since 1998. Thelma spent 20 years as an emergency nurse at a level 1 trauma center. She worked for NHTSA Region 5. She served on the National CPS Board twice. Illinois has an award named after her, the Kuska Lifetime Achievement Award. That is the highest individual CPS award in Illinois. I could go on for days telling you about all of the awards she has won and the incredible work she has done for traffic safety. Unfortunately, we don't have time for that today. So, take it away, Thelma.
Thank you. Thank you, Diane. Can you hear me? Good morning. Can you hear me?
We can hear you, Thelma.
Okay. So I have the pleasure of introducing our opening speaker this morning, Dr. Mark Zanfrelo. Mark, MD, MSCE, is a pediatric emergency physician, a clinical epidemiologist, and associate professor of emergency medicine and pediatrics at Hasbro Children's Hospital and the Alpert Medical School of Brown University. With over 125 peer-reviewed publications, Dr. Zanfrelo's research focuses on pediatric injury epidemiology with emphasis on risk factors for motor vehicle occupant injuries, concussion, and disabling injuries in children. Dr. Zanfrelo earned his medical degree from Alpert Medical School of Brown University and a Master of Science in Clinical Epidemiology from the University of Pennsylvania. He completed his residency and chief residency in pediatrics at Yale New Haven Children's Hospital and his fellowship in pediatric emergency medicine at the Children's Hospital of Philadelphia. Believe me, Mark is a wonderful doctor, and I wish I had a chance to work with him in the ER. What this bio doesn't say is that he has helped me with my research on awareness of and education for emergency nurses and child passenger safety. But please join me in welcoming my good friend, Mark Zanfrelo.
Thank you so much, Jennifer and Thelma, for that very kind introduction. I am so thankful to be here. This is my second visit to the Illinois Statewide Child Passenger Safety Conference. I was here quite a few years ago and really enjoyed presenting. And so maybe some of you were there that time. And it's great to be back. I know we're virtual, and I'm happy that we're all staying safe. I wish we could be together right now, but I know we will be in the future soon. So I'm going to share my screen. Okay. Can someone just in the chat say that they can see the presentation okay? Okay,
this looks great.
Thank you. Wonderful. So today I'll be talking about parent and healthcare provider knowledge, attitudes, beliefs, and practices surrounding child passenger safety. So I want to tell you a little bit about the Injury Prevention Center at Rhode Island Hospital and Hasbro Children's Hospital. Rhode Island is a really neat state. It is it's a small state, about 1 million residents, and it's been that way since the 1970s. I'm a Rhode Island native, and as Thelma mentioned, I went to a few different places for training and then came back to Rhode Island. Little fun fact, about 80% of Rhode Islanders who were born here stay here for life. Another 10% leave and come back, and then that's me, and then another 10% leave and stay away. We have a mission at the Injury Prevention Center at Rhode Island Hospital to reduce injuries in our region, and we develop and implement community-based injury prevention projects. We conduct injury research and educate health professionals, and we also help influence policy and educate the public about the burden of injury in Rhode Island. So just some outline. I'm going to talk a little bit about the burden of motor vehicle crash injury in children and youth, and talk about current best practice recommendations for child restraints. And then again, the focus is going to be on the knowledge, attitudes, beliefs, and practices about child passenger safety of pediatricians, emergency medicine physicians, emergency medicine nurses, and parents. So this is the leading cause of injury deaths in 2018. You can see here that 1 through 5 in children and youth up to the age 25, we have unintentional motor vehicle traffic as the first, second, or third cause. One interesting thing to note here is that it used to be in ages 1 through 25, the #1 cause. So, you know, when I started talking and lecturing about injury prevention about a decade ago, it was the #1 cause in ages 1 and above. So we've made strides, which is great. But what I'm going to try to describe today is that although we've made strides, we still have a ways to go. So the CDC has called motor vehicle injuries a winnable battle. It's one of the 10 winnable battles, which includes child occupant protection and also teen driving. And of course, I'm just going to be focusing on child passenger safety today. And when we think about traffic injury prevention, we talk about primary, secondary, and tertiary prevention. Primary prevention is preventing the risk and reducing the risk of a crash. So that's focusing on things like reducing distracted driving, drowsy driving, aggressive driving, and inexperienced driving. Secondary prevention is the crash is already happening and it's going to happen. How do you then reduce or mitigate injury given a crash? And so you want to try to reduce injury incidence and severity. And that's where things like car seats, seat belts, airbags come into play. And then tertiary prevention is the crash has already happened, the injuries already happened. How do you then increase survival and decrease recurrence of injury? And so that's everything from EMS systems to ED care, trauma care, et cetera. So we're going to be focusing a lot on the primary and secondary prevention today. And of course, when we think about injury prevention, we can also frame it as the 4 E's: engineering, education, enforcement, and economics. Engineering, of course, is the design of car seats and seat belts in vehicles. Education is providing information to end users and stakeholders. Enforcement is providing laws, legislation, and policy. And then economics is providing incentives or disincentives. If we look at some of the history of child passenger safety, you can see we've come a long way. I like this one where, you know, the child has sort of a dummy steering wheel that they're using, but they're right front and center in the vehicle. Of course, we may remember this in the 50s, 60s, and 70s, and even 80s, piling up in the back of a station wagon. And of course, you know, there weren't a lot of restraints or restraint use for a long time. When we saw the first car seats developed by Sweden, where we then saw a little bit of uptake in both the development of restraints, laws mandating them, and then the use of them themselves. And so that takes us all the way to 2018, where the American Academy of Pediatrics published an updated policy statement and technical report on child passenger safety. So the policy statement was the policy and the guidelines, and the technical report was really focused on the evidence and the research. That was the basis for the policy statement. Lead authors were Dennis Durbin and Ben Hoffman, who I'm sure you know in the child passenger safety world, really prominent researchers. And I was one of the co-authors on the executive committee for the American Academy of Pediatrics Injury Council. And of course, we all know this. I'm not going to go into this in detail, but basically choosing the right restraint for your child, starting with rear-facing seats for infants until they exceed the weight or height limit of that seat, which can be, you know, 2, maybe even 3 years old, depending on the infant and the seat. Forward-facing car seats until they exceed the weight and height limit of the seat. Belt positioning booster seats until the belt properly fits. And so that's typically around 57 inches, 4 feet 9 inches, and between 8 and 12 years old. And then a seatbelt only when it properly fits and staying in the rear of the vehicle until 13 years old. And as you can see from this diagram from NHTSA, there is a spectrum here. There's a spectrum for all of these types of car seats. And so there's not necessarily a hard and fast rule, particularly when it comes to age. So the first study I'm going to discuss is pediatricians' self-reported knowledge, attitudes, and practices about child passenger safety. So the objective here was to evaluate their self-reported knowledge, attitudes, and dissemination practices. And we distributed the survey to pediatric primary care physicians and via the American Academy of Pediatrics email distribution list. So this was a national distribution among pediatricians. And we had over 500 respondents to the survey. And we had a number of different items that included knowledge and scenario-based items. And we had 6 of those that were distinct and covered various types of child passenger safety knowledge. And 52.9% answered all 6 correctly. So we identified those as a high knowledge group. They were more likely to be female, for obvious reasons, because women are the superior sex. They're more likely to have completed a pediatrics residency, and they're more likely to have a child themselves, which makes sense because if you have a child yourself that you're restraining, you are going to have that working knowledge. If you look here at this bar graph, you can see the high knowledge group is in blue, and the not high knowledge or lower knowledge group is in green. And what this graph is showing is the frequency of counseling. So how often pediatricians would talk to their patients and their families, of course, about child passenger safety. And on the x-axis is the age group of the patients, and on the y-axis is the percent where they provided counseling often or always on a 5-point Likert scale, so the first two of those scale. And what you can see here is a difference where the higher knowledge group were more likely to provide counseling than the lower knowledge group. And all of these were statistically significant. And when you say, and we're going to talk about p-values, which is just a statistical way of saying if something is significant or not, and if it's less than 0.05, then there's a statistically significant difference. And you can see for all of these groups, there was a statistically significant difference where the higher the knowledge was associated with them providing it more frequently in counseling. So this is an association, it's not causation, but it kind of makes logical sense. It has some what we call face validity. It makes sense that if you're more comfortable with something, you're more likely to, maybe talk about it because you're more knowledgeable. If we look at some of the more common barriers to evidence-based counseling, the pediatrician said there was inadequate time, the office was not trained, and there were competing priorities. As many of you know, if you have children, you go into the pediatrician's office, there's a sea of evidence. So there's a lot of challenges and barriers. And the most common strategies used to provide counseling were prompts in the health record, educational resources, adequate time, and information provided in office staff. I think I saw something in the chat that said, what was the 52.8% of the high knowledge group? Thank you for that question. What it was there were a number of questions in the survey, and 6 of them were knowledge-based questions. Basically, when should a child go from rear-facing to forward-facing? Or they would have a scenario. We have a 8-year-old who is 50 pounds and is 4 feet 2 inches. What is the proper restraint they should be in? So there were 6 of those questions. And the 52.9% was the percentage of the total group who answered all 6 of those questions correctly. And so they were the high knowledge group. This looked at the confidence as compared to knowledge. And what you could see is that we have rear-facing car seats, convertible and forward-facing booster seat, when a child can be in an adult seatbelt, and when a child can sit in the front seat. So the higher the knowledge, the more confident they were about providing recommendations, which likely corresponds to the previous slide in the graph where their knowledge was related to them actually providing the recommendations. So we see a high correlation here between knowledge and providing recommendations and knowledge and confidence about providing recommendations. Because when you think about any type of behavior, so whether it's pediatricians providing child passenger safety advice, or parents actually buckling their kids correctly, securing their kids correctly, restraining them correctly, if you have, the more knowledge you have and the more confidence you have, the more likely you are to have those behaviors. So inadequate time was a major barrier, as it is, as we know. We never have enough time. And so, but there can be ways in which we can utilize technology in screening. For example, you can integrate things in the electronic health record. Well, you have the child's age, you have their weight, you have their height if they're coming in for a regular checkup. Okay, tell the computer age, weight, height, this is the recommended restraint for that child at that given moment. And you send that prompt to the pediatric provider. So they don't necessarily have to think about it or stop and look at the chart or remember what they learned. Boom, it's right there in front of their face. So these are some strategies to overcome some of those barriers. The bottom line is that although child passenger safety knowledge is generally high, there are knowledge gaps that exist, and that knowledge is associated with attitudes, practices, barriers, and facilitators. And there's a lot of opportunities to increase this knowledge. So let's look at emergency physicians. We know pediatricians care for patients in the primary care setting, but to be honest with you, after the second year of life, kids usually only go to their primary care doctor once a year at the most, maybe more frequently if they have an acute illness, but there may be gaps in when they see their pediatric provider. And so other healthcare providers may be able to sort of fill in those gaps. And so this was a survey by Dr. Michelle Macy, who's now at Lurie Children's in Chicago, looking at emergency medicine perspectives on child passenger safety. So she interviewed 600 pediatric emergency medicine physicians and 600 emergency medicine physicians, general emergency medicine physicians. And this was very important because about 80% of children in the country who seek emergency care actually do so in the community emergency department setting. And so you don't always have specifically pediatric emergency medicines like myself or Dr. Macy caring for those children. And so they did a similar type of survey. And what was interesting was that the majority of the physicians agreed that it is their role to educate parents about child passenger safety. These percentages were actually much higher than I expected from emergency physicians. Because when we think of emergency physicians, we don't think of longitudinal care or having an ongoing relationship with somebody. But that being said, you can make a difference. There's this teachable moment when you come into the emergency department. And in fact, the majority of the physicians said that they could make a difference. And so they asked a few questions of these physicians, and they had these hypothetical scenarios. And although they said that it is their role to educate and they can make a difference, they actually did not frequently provide the best practice safety recommendations to families. And so there's an opportunity there, again, for to capture a different healthcare venue where providers can provide child passenger safety information. And so this is important for potential future interventions. Well, what about emergency nurses? Well, Thelma Kuska, who introduced me, she is so dear to my heart. She approached me a few years ago and said, I want to do what you did, but with emergency nurses. And I said, that sounds like a great idea. Let's do it. So we sent a survey to actively practicing emergency nurses and to assess their knowledge, beliefs, and practices. And nearly 1,000 completed the survey, which is, by the way, a testament to Thelma's amazing just force. I mean, that's more respondents than we had in any of those other surveys we mentioned. We had a similar thing where we had 6 child passenger safety knowledge and scenario-based items, but they were only identified correctly by 18.8% of the sample. So not even 20% answered all 6 correctly. And when we looked at the lower knowledge versus the higher knowledge, we looked at sort of barriers as to why they may or may not provide recommendations. And a lot of it was inadequate understanding or being unaware of child passenger safety guidelines. The ED staff was not adequately trained in the car seat safety, or the parents were not interested in learning about motor vehicle safety. And just as a point of reference, when we look at this chart here, the bolded ones are the ones that were statistically significantly different in the lower versus high knowledge group. That's that p-value that is less than 0.05. And so we identified barriers to providing recommendations to parents of children less than 2 years of age during ED visits. And again, because emergency department visits for children in the US nationally, 80% of those occur in general EDs. It's important for both the physicians and the nurses to have some knowledge of child passenger safety guidelines, or at least be aware of where can they identify that information. I think a lot of our training as clinicians, nurses, anyone who works in the hospital is not necessarily you have to remember every last little detail, but you have to know where to find that information and you have to know where to access it. So the bottom line is that emergency nurses, like emergency medicine physicians, can improve their knowledge, confidence, and provision of child passenger safety in the emergency department. And confidence in topics was associated with knowledge. This was a study looking at parental behavior, and they were saying, are parents following the recommendations for keeping children younger than 2 years rear-facing during motor vehicle travel? And this came out from following the 2011 recommendations, looking at keeping children rear-facing longer. And basically, it was a study of drivers transporting children collected at 25 convenience locations located in Indiana. And they basically saw that there was an increase in percentage of children kept rear-facing compared to from the 2007 to 2009 compared to 2012. And this was especially noticed in the 12 to 23 month age range, which is great. And I think, as you'll see in some future slides I'm going to show during this hour from the National Highway Traffic Safety Administration, we are making strides in kind of moving the needle in the right direction. This was another similar one, sort of looking back on rear-facing car seats. Again, a similar idea. And this was the parents switching their 1 to 4-year-old children forward-facing. So this is sort of the opposite question of the prior study, but the same result. So did you switch your child 1 to 4 years old forward-facing before 12 months of age? A third in 2011 did, and only a quarter in 2013 did. And then at 2 years or older, 16% did in 2011 and 23% did in 2013. And what they noticed was that younger parental age, less education, lower household income, and rural residence was associated with transitioning at or before 12 months, so prematurely. And I'm going to talk a little bit about the disparities that we're seeing in child passenger safety. We're actually making great strides in some of the age groups. Kids less than 2, kids less than 4, a huge proportion of them are restrained correctly. We're not doing as great in the 4 to 10 age group, but we are making some strides. But what is known in all the age groups is that even though we're making strides, there are disparities that exist. And in certain populations, we're not seeing as much of an increase in restraint use. And that's right for targeted intervention. So while there's increased adherence to rear-facing recommendations, there are still opportunities to further improve behavior. So these next two studies were done by Dr. Catherine McDonald, who's a PhD nurse at University of Pennsylvania, myself, and a couple of colleagues. And we did one major study and then looked at 2 different types of questions. One was called situational use of child restraint systems and carpooling behaviors. So what did parents do when they had a slightly different scenario, whether it was, oh, I'm taking a quick trip, or I'm in a taxi, or I'm carpooling. And then the second study was factors associated with cell phone use while driving. And we'll look at the results of this. So parental driving behaviors can contribute to crash-related injury, because if you have distracting driving in the parents, of course, that's the primary prevention you want. If you have distracted driving, that increases your risk of a crash. If you have suboptimal compliance with child passenger safety recommendations and the child's not optimally restrained, then given a crash, you're more likely to have a more significant injury or a fatal injury. And most importantly, modeling of unsafe behaviors can be detrimental to children as they mature. As soon as they're facing forward, they're looking at you. And if you are distracted, if you're on your phone, if you're texting, if you're calling, even if it's hands-free, kids are seeing that. And as they become older school-age kids, preteens, and then teens who are learning to drive, well, you've modeled a decade of behavior for them. So keep that in mind. I know it's, I try to do my best and keep that in mind as well. So the aims in this were to describe factors associated with suboptimal practices in parents of children age 4 to 10, look at mobile phone related driving behaviors, and then examine association between those and various behaviors. So it was for parents who were English speaking and were a caregiver of a child 4 to 10 years old. And we recruited through this online methodology called Turk Prime. And so we were able to get a national sample. And so at the end of the day, 783 were included in the sample. I'm not going to break down all these statistics, but you can see there was a distribution. 60% of the sample were female. A large proportion of the sample were in their 30s and 40s. The majority of the guardians who responded were the mother. The majority were white, which this is important because this does not reflect at all the demographics of the United States. And so even though we were able to capture all of the states, this doesn't reflect the demographics of the US, which is very important when talking about generalization of your findings. And then a lot of the participants had a bachelor's degree or an associate degree. So when we looked at the restraint type, this is the distribution here. And when we looked at the restraint type based on frequency of use of that restraint, you could see that the overwhelming majority said that they used a restraint on every trip. However, once or twice, greater than 1 or 2 times, but less than half the trips, or greater than half, but not every trip, there was a not insignificant proportion in each of these car seat types that didn't use the restraint. Most notably here, in the booster age range, which I'm sure anecdotally we know. You have a kid who should be in a booster. Maybe they don't use that booster, but instead they use a seatbelt instead. So this is not to say that they were unrestrained during these times. But this is to say that they were probably improperly restrained or suboptimally restrained. And then how often in the back seat in the last month? A large proportion of them were never. But again, you have kids. Remember, this is a sample that's 4 to 10 years old, and you have a large percentage that were not in the back seat. So when we look at this gets a little busy, but I'm just going to sort of describe it based on the color codes. So this says, I would allow my oldest child between 4 to 10 years old to ride in a car not fully buckled in their child restraint when. And so child is asleep, is fussy, is embarrassed. I know my daughters have said that, Dad, why do we have to be in this child seat? Be quiet, get in it, or we're not going anywhere. A reward, traveling overnight, which I thought was interesting. I don't really understand that one. On vacation, if they climb out of it, someone is holding the child, a rental car, grandparents' car, driving just around the corner. Car is too crowded to fit the child restraint. There aren't enough child restraints for the number of children. The child restraint is missing from the car. You're riding in a taxi or car share, which we're seeing increasingly, especially in urban areas, in a rush, or a child in a car without a child restraint. And so the someone said airport bus. That's another good one. We should add that to the next survey, because often the airport buses don't even have restraints available. So this says strongly agree, somewhat agree, neutral, somewhat disagree, and strongly disagree. And what I want you to focus on is the sort of the 2 red ones. These don't project very well as different, and for some ways it doesn't matter. This sort of more cherry red and this kind of duller stained rust red. You can see here that anywhere from about 3% to up to more than 20% say that I would allow my oldest child to ride in a car not fully buckled in their child restraint when these various situations occur. And this is very concerning. We look here at riding in a taxi or car share. That's a very high percentage. And someone's saying in the thing, I know people who don't use car seats on an overnight travel so they can sleep flat. That's really concerning. And so this is our target population. These are the people who will sort of bend the rules, if you will, in certain situations. In the last 3 months, among booster seat users, my child rides in a booster seat when I'm driving. His or her friends who do not use booster seats, I ask other people to have my child use a booster seat when they're driving, or I've given other people a booster seat to use for my child when they're driving him or her. Again, rarely or never, and sometimes, these are not small percentages. So let's look at mobile phone related driving behaviors among parents of children ages 4 to 10 years. So phone behaviors while the car is stopped, these different types of behaviors: talking on a handheld phone, talking on the phone being hands-free, reading texts, sending texts, using social media, or emailing or browsing the internet. So the question was, in the past, I think it was in the past 3 months, how often do you do any of these phone behaviors? And you can see here, again, the sort of the bad and the red is on this side of the graph. But you can see here, as stopped, yes, like stopped at a stoplight. And so you can see here that anywhere from 5 to 8% said that while the car is stopped, they may do these behaviors. Now, how about where the car is moving? Not too much of a different. The key here is a little bit different, but if you look every trip and more than half of trips and not every trip, you can see the percentages are not that different. About 3 to 8% of drivers, depending on the behavior, will still do these things on every trip or more than half the trips, but not every trip. That is a huge percentage when you think about the absolute number of people on the road and their roads and their miles driven. So what about suboptimal driver restraint? So in the last 3 months, how often did you ever at any time use a seatbelt when you were, meaning the driver, the caregiver, driving, riding as a passenger, or riding as a passenger in the front seat? Again, never or once or twice, anywhere from 5 to 15% if you combine those two categories. That's really important because we do know that children who are, or rather parents and caregivers who don't practice safe behaviors themselves will often either bend the rules or not systematically or every single time practice safe behaviors for their children. And now, drowsy and impaired driving behaviors among parents of children ages 4 to 10 years. In the last 3 months, how often did you ever at any time, no matter if your children were in the car, drive while you were too tired to stay awake, buzzed, high, or lightheaded from a medication over the counter, buzzed, high, or lightheaded from street drugs, buzzed, drunk, or lightheaded from alcohol, or buzzed, drunk, or lightheaded from marijuana? And you can see here, I mean, these are seriously impairing behaviors. 3 or more times, twice or once, a huge percentage of the population. Once to 3 or more times for more than 20% when they're too tired to stay awake. And then buzzed, drunk, or lightheaded from various substances, anywhere from about 3 to 5% to about 8%. That is very high. And I see a note in the chat that says, I honestly feel like percentages should be higher based on me driving and seeing parents in their car driving with kids. And I think you're right on. Think about it for a second. Even though these surveys were anonymous, it's likely underreporting, right? So the problem is likely worse than what we're actually capturing. So I think, so Irene, you're right on with that comment. Association between parental characteristics, child passenger characteristics, and various driving behaviors. Well, compared to those who are always use their typical child restraint, participants who did not always use are more likely to, while driving, talk on a handheld phone, read a text, send a text, and use social media. So again, we're seeing these association of behaviors, which is really important. We see that in other health-related behaviors too. if a person doesn't kind of sort of take care of themselves in one way, they might not be taking care of themselves in another way. And, kind of the same thing we're seeing here in children. And so again, it's an association, but we need to make sure that we have targeted interventions to these populations with their certain health behaviors. Higher income, not wearing a seatbelt on every trip, and driving under the influence of alcohol also associated with distracted use, which is interesting because, when we think of a lot of disparities in anything, in any type of health behavior, including injury prevention and child passenger safety, we sometimes think about disadvantaged individuals, lower income, maybe lower education. But in this case, higher income was associated with distracted use. So, you have to think about that for a second. Someone just said, I have to take this call or text right now, or it can't wait. Yeah. You could see the sort of type A, maybe a corporate type person, or someone who's very addicted to their phone saying, I have to do this right now, when absolutely it's not an emergency. So the limitations, again, the generalizability of the results. We didn't have a full spectrum of the population demographically that represented the entire US. And in general, this mechanism, the participants are more educated, less diverse, and have a higher income than the general population. Someone said, maps and directions, I found more people looking and using while driving when you're on patrol. Absolutely. And especially if they have their phone, but they don't have a stand for it or something, it's down in their lap. They're looking down, they're looking at directions. And so these are really important things to consider. So the bottom line with distracted driving and situational non-restraint is that inconsistent child restraint systems use, lack of seatbelt use, and driving under the influence are associated with parent and caregiver cell phone use while driving. And there are situations where parents are comfortable with non-restraint, and those are important areas for future targeted interventions. I'm going to spend the last few minutes talking about the national survey of the use of booster seats. The National Highway Traffic Safety Administration has this occasional survey on the use of child restraints among children being brought into gas stations, fast food restaurants, etc. And so there's a sample methodology that's designed so results are representative of children who frequent these types of sites. And so these are booster seat use and national estimates for children about 4 to 7 years old. Take a look at this for a second. So it's been pretty level from 2006 to 2017. Now, that may also represent the fact that as time has gone on, we see more kids who are in forward-facing harness-based restraints for longer periods. But I'll get back to this in a second. So this is comparing 2015 in the olive to 2017 in the gray. And you can see restraint use for children 4 to 7 years old. Again, in car seat, we're seeing a higher percentage of those in harnesses, which is great, and a lower percent in seatbelt, but about the same percent that are unrestrained. And I think that one of the questions was, what do you think the biggest factor is for parents thinking kids don't need boosters? Well, they've done some studies on that, and at the end of the day, there are a few things. One is lack of knowledge of the need of a booster seat. Oh, my kid's big enough. He or she's can use a seatbelt. Two is what everyone around them is doing. So everyone around them could be their community. Everyone around them could be their family. Everyone around them could be their friends. And so there are a number of factors that affect booster seat use. This is looking at restraint use for children 4 and 5 years old specifically. And again, nicely, from 2015 to 2017, these are the latest data, we're seeing an increased use of harness-based car seats, which is fantastic. This is for under age 1. This is great. We're kind of plateauing, which is okay. But again, under 5%, 5% are using a forward-facing car seat under the age of 1, and 2% are still unrestrained. You know, this is really important because, as you know, with anything, it's like when you think about weight loss, you know, you can lose a lot of weight quickly and then you kind of plateau and then it's harder to do. The same thing here. We're so close, you know, we're over 92% of kids under the age of 1 who are in a restraint, which is fantastic. But now we need to find out who are these people that are still not using it and how can we have targeted interventions. Christopher says, one factor I see is other parents don't use it, so they give in, which is absolutely true. I always say that I'm getting a little bit of feedback. I don't know if there's another audio on. I always say that it's like, you know, you can negotiate with your kids eating broccoli, but you never negotiate with car seat safety. And you make it the expectation, on every trip. This is restraint use for children 1 to 3 years old. And sorry about that. And again, you're seeing a little bit of uptick in rear-facing car seat because they're accommodating kids of that age. You know, we know in Sweden, for example, they've been rear-facing up until age 4 for well over a decade and a half. And this is restraint use for children 4 to 7 years old. Again, you're seeing a nice little spike here in forward-facing car seat. Kids are staying in that forward-facing harness for a long period of time. As you all know, you're in the CPS community. These seats can accommodate kids of very high weights and tall heights. And then restraint use for children 8 to 12 years old. This is where we're kind of plateauing. You know, we're seeing these are basically statistically significantly the same. So 2015 to 2017. We need to get more children 8 to 12 in booster seats. And that's a really important target that's ripe for intervention. When you think about it, 40 years ago, there weren't any booster seats, right? And you know, the laws just started coming into place maybe 20 years ago. So it takes about a generation for things to really uptick. We've done a really good job with the younger kids. You know, now we need to focus on the older kids. I just want to go forward a couple slides because I want to show some disparities. So this is child restraint use by age and Hispanic origin in 2017. And so you can see here that while overall, particularly in the 0 to 12 month age group, it's very high, there are disparities that exist. Black and non-Hispanic children are less likely to be restrained actually in all of these age groups, as well as Hispanic, non-white, non-black, or non-identified, or sorry, Hispanic of any race are lower in the 4 to 7 and the 8 to 12 age groups. So these things are ripe for targeted interventions. So what I'm going to do is, I think I'm just going to fast forward a little bit to the end because I do want to get some time for questions. We just have a few minutes left. I think that for the future, our current goals are similar to our historic ones. We want to minimize and eliminate child occupant death. We want to attenuate short and long-term disability, and we want to mitigate injuries requiring medical attention. These have always been the goals. But the thing is, everything changes. You know, vehicles have changed, the size of the vehicles, how fast they go, how many passive and active types of restraint and safety systems they have. Kids have changed. Kids have become more obese in the past 40 or 50 years. And so that's really important when considering, okay, weight limits to car seats or the kinematics and the biomechanics of a crash of a child who's overweight. I've done some research on that in the past and found that there are some risk factors of injury when a child is overweight. The car seats have changed. We've had newer design car seats. We've had car seats that are, you know, convertible, and the car seats have had to accommodate the changes in the vehicle fleets and the changes in the children, and the policies and the laws have changed. And, you know, this is really important because when all of these things change, we need to continue to measure this. Because some people say, oh, okay, well, you did this research 5 years ago, 10 years ago, we know what the answer is. No, some of these studies that I presented today are ripe for repeating with all of these changes. Future advances must be data-driven. Surveillance data. So surveillance data is so key. We need to continue to understand what people are doing. Technical data, black box data, of vehicles that are instrumented with different types of very advanced technical elaborate systems. Using those data in order to find out exactly what's going on. There's been a huge push to look at what's called naturalistic driving. Someone mentioned, oh, I know people who have their kids unbuckled at night so they can lie down. So, in an ideal world, in a laboratory, you have a crash test dummy, what we call an ATD, and they're kind of doing this. What does a child do? They slouch, they lean. All this sort of what happens in the real world. And then big data, administrative data, social networking. We have health insurance reimbursement for car seats. We reimburse everything else. Why don't we reimburse car seats? In fact, there's data to show that it's just as effective as other types of health prevention initiatives. And then use of electronic health record to screen for safety practices and provide customized recommendations. So what we call precision prevention. What I mentioned earlier. Okay, you have a kid who's a certain age, certain height, certain weight, boom, you make that recommendation that's specific for that child. So in summary, crashes are the leading cause of death and disability in children. Proper restraint selection and installation can reduce injury and fatalities. Increased knowledge of and adherence to newest recommendations by providers and parents. But there's knowledge gaps and non-adherence that still exists for both providers and parents. And improper restraint selection and misuse is still very prevalent, and continuing education and data-driven interventions, including technology, are important to overcome barriers to knowledge and behavior. So these are my daughters. They're just about 11 and 9. The 11-year-old Ella is very tall for her age, but I made her stay in her booster until she was 4 feet 9 inches. She wasn't too happy about that. But, we have to do what's right for her. And of course, she's still in a booster right now. So I want to thank everyone. This was a wonderful opportunity. I think that the thing that I really enjoyed about it and was a little bit unexpected was the ability to sort of respond to some of these quick queries and questions in real time, which I really enjoyed. And I know we have a few minutes, or we may have a few minutes more for question. I'll defer to Jennifer for that. But thank you again.
Thank you, Dr. Zanfrelo. That was awesome. You had a lot of good comments and questions that came up in the chat. If you have a question for Dr. Zanfrelo, please submit it in the Q&A box. It's located in the bottom right corner of your meeting window. You may need to click the button with 3 dots to see that option. If you've submitted a question, I'm going to go through here in a little bit and kind of give Dr. Zanfrelo a few questions, and we'll see what we can get to in the short time that we have. Okay, Dr. Zanfrelo, one of the questions was asked if you would be able to share your slides. So I just wanted to give you that opportunity to answer that.
Yes, I can make my slides available. I'll probably end up doing it in a PDF format just because the slide deck is pretty big.
Sure.
Yes, I'm happy to do that. Okay,
great. Let's see what else we have here. Sorry, we'll try to get to as many as we can. I'm trying to scroll through here.
Sure.
Let's see. It says, well, I totally agree with health insurance reimbursement for child safety seat use. How likely are we to realize this initiative, especially with insurance companies trying to minimize their costs and maximize their profits?
Well, you bring up a really good point. My response to that would be, show them the data. The University of Pennsylvania did a really great cost analysis looking at child seat distribution and showed that it was equally as effective in preventing adverse health illnesses as would, or in this case, injury as vaccine distribution and reimbursement would be. when you think about it, car seats are pretty cheap, especially, I don't mean cheap for everyone. I know some car seats are hundreds of dollars. My point is, from a public health perspective, when you compare car seats to like an emergency department visit for, injuries sustained in a crash, or when you compare it to other preventive health measures, like drugs or surgeries or things like that, it's relatively inexpensive. So how close are we to realizing this in actuality? I don't know. But what I do know is that there are certain states who have, like Massachusetts, who have initiated such a reimbursement programs, and it's worked out fairly well. I think, again, providing the data, you have to show the data to your legislators and policymakers and say, look, we don't necessarily, we can provide this as a service, and it will prevent injuries and crashes. And maybe do it as a targeted thing. We already have greater than 92% of people in rear-facing seats, particularly in the first few years of life. Maybe we target just for booster seat age and eligible kids, which, by the way, it's the cheapest form of a restraint that you can buy. So it's a good question. I think at the end of the day, it's showing the data.
Thank you. And another question is, have you noticed that cultural and language to be a barrier when teaching about car seats?
Absolutely. Look, when my girls were first born, I remember struggling with my car seat. I was scuffing up my knuckles. I was swearing. I still couldn't get a good fit. And I'm in the biz, you know what I mean? And so then now take someone who maybe in their culture, either if they came from another country where car seat use wasn't as prevalent, or just in their culture in general, it's not used. They don't speak English. Maybe they're not educated. Absolutely, those are huge, huge barriers. And so that's why we need to target individuals who have the most amount of barriers and try to identify the facilitators in order to increase use.
Thank you. And then somebody else asked, there was a NHTSA car seat recommendation sheet, and it said that children are able to forward face at 1 year old. Is this correct or a typo?
So, so even if you look on this graph here, forward facing car seat at 1 year old, I think that I don't know when that was from. This graph is a little bit dated. I think at the end of the day, we just have to follow the recommendations that if your child is still under the rear facing weight and height limit of that seat, keep them rear facing until they exceed that weight and height limit of that seat. I know there are anecdotally concerns of, their feet are all bunched up. I have a big kid, their feet are all bunched up. I'm worried about like a leg fracture. Well, I would take a leg fracture over a spine fracture or a head injury any day. I've also heard the complaint or the concern, well, I'm worried about stunting my child's social interaction and sort of social growth. And my response to that is, well, how long are you spending in the car? So I understand these types of concerns, but follow the data. And the fact of the matter is, keeping rear facing till as long as possible is important. I suspect that, and I don't want to speak for NHTSA, and I don't remember when that is, but I suspect that's probably, okay, you have a huge kid and your seat doesn't accommodate their weight or height rear facing sort of at that age for that particular child in that particular seat. And that would be a situation which you could. But I know overall the recommendation is to keep them rear facing as long as possible.
And then someone wants to know if there's software available to enter a child's height and weight to generate the best car seat for them.
I don't, but I can look into that. I do know that there were a couple car seat apps by a couple children's hospitals, and I don't remember the specifics, but I can look into that and get back to the group.
Okay, let me see this next question. Has there been any consideration of including fighting children as a distraction? It can be just as, let's see, hold on, sorry. It can be just as distracting as a driver using phone, if not more so. Or how would it be best to educate parents on dealing with this issue?
Sure. Yeah, no, it happens. Fighting children is a distraction. I think we see some vehicle commercials about that now, right? And then it's like that the vehicle stops on its own because you turn around to see your kids arguing. I would say that it's a zero tolerance thing. So if you can safely pull over to the side of the road and stop the vehicle and address the arguing, do that. And but there needs to be discussions and consistent expectations and discipline sort of all the time, right? I know we didn't talk about teen driving today because it's not really relevant to this discussion, but we know that, for example, parenting styles are associated with how safe teens drive. And so that's sort of like a parenting thing that kind of is ongoing, and an expectation that, if you're going to start arguing, we are going to pull the car over, don't make me pull over type of thing. But I would say that just like anything, you want to avoid getting distracted by anything in the vehicle, whether it's you drop something or you're going to change the radio or change the heat or whatever it may be.
Okay, and I think we'll end with this one last question. What interventions were done to increase the knowledge and confidence in emergency room staff for CPS?
Yeah, so actually Dr. Macy has a large grant that I think is just ending up looking at that. And at the end of the day, it's any type of intervention needs to focus on the barriers and facilitators. And so in order to change behavior, you have to understand why someone is or is not behaving a certain way. And so I think what she did was she conducted focus groups and sort of asked them, well, why don't you, why don't you have that knowledge, or why don't you provide that information? And then they gave that to her. And then she had, I believe it was an electronic health integrated type of intervention where it was almost like integrated machine learning, where, similar to, it's not just height, weight, and age, but also provides sort of like real-time education. Oh, okay, this child is here for this. Remember, they should be in a forward-facing 5-point harness car seat still. So those types of interventions are important. And while it is important, and I think the most important thing to consider is that those interventions have to be specific to that population. Now, certainly it'd be generalizable if it happened in one academic pediatric emergency department to another, but that might be different from like a general or community emergency department where you might have providers who have different sets of barriers and facilitators.
Okay, thank you for that. Well, we've come to an end to our first session today. Thank you so much, Dr. Zanfrelo. That was amazing. That's a lot of good information. He has his email up on the screen, so I'm sure if you have a specific question for him that we didn't get to today, he wouldn't mind taking your question in an email. So thank you again, Dr. Zanfrelo. We really appreciate it. I know there's 800 people clapping for you virtually. We just can't hear them all.
Thank you very much. Thank you.
You're welcome. So you may see your participant packet for connection information to the next concurrent session of your choice. When you're done here, please close out the browser completely before clicking the link to join the next session. If possible, try to join your next session before stepping away to take a break. And thank you again, Dr. Zanfrelo. That was amazing. And thank you, Thelma, for the wonderful introduction.